Yes, no, you can start. Yes.
Okay, thank you very much. Hello, everybody. So today it's for me a pleasure to introduce Professor Frederick Lowers. He's a professor of maxillofacial surgery and also is professor of anatomy. And he's the head of Department of Maxillofacial Surgery in Toulouse University Hospital. And also he spent part of his time to operate and teach in foreign countries, mainly in Cambodia, where he used to go twice a year. So, Frédéric, thank you very much to participate to this program of lecture and to help our Myanmar friends. Thank you very much. You can speak.
Thank you, Professor Jerondi Gauzy and Professor Frederick Lowers. Today, lecture is maxillofacial injury is the most common injury in our country because of our peoples are a lot of sign accidents. So many road traffic accidents very much associated head injury and maxillofacial injury. I'm a neurosurgeon, so the maxillofacial surgeons are very good friends with the neurosurgeons. We have the divided region, but the eyebrow is concerned with the neurosurgeon. Below the eyebrow is concerned with the maxillofacial surgeon. We are divided. Which patient admitted to which what? But the eyebrow, there is the lacerative in the forehead, patient admitted to the neurosurgical ward. The lacerative in the ears, the face, patient admitted to the maxillofacial ward, but the patient is unconscious. First, the patient first going to the neurosurgery, and then we next refer to the maxillofacial surgeon as usual in our country, like that. So today lecture is very interesting. The day of the alo jesu de bare lo da general passin sene ni dai ni kin 12နာရီမှာပေါ့နော်ပြီးခဲ့တဲ့ပတ်ကတော့ညနေ6နာရီခွဲဖြစ်သွားတာပုံမှန်ကတော့နေကင်း12နာရီပါဗျကိုယ့်ရဲ့ဟိုပါပေါ့ပေါင်းသင်းတွေလည်းအားလုံးလည်းလက်တို့ပြီးတော့မှဒီလိုနေကင်း12နာရီရောက်တိုင်းမှာဒီလို lecture လေးရှိနေမှာပါလို့ပြောနော်အားလုံးတက်ရောက်ပြီးတဲ့လူတွေရောအားလုံးကျေးဇူးတင်ပါတယ် Thank you so much for Professor Jerondi Gauzy and Professor Frederick Lowers. Thank you for giving your time to our Myanmar people, and you start our Myanmar people. Thank you so much for your effort, all the efforts to the Myanmar doctors and the Myanmar people. Thank you so much.
Okay, thank you.
Yes, thank you very much for the invitation. So let's go. We're going to talk about maxillofacial trauma. And well, I don't know exactly what you need, so I'm going to talk about all the problem that you can meet with that kind of trauma. So the first problem is not so often happening, but you can have some life-threatening emergency in that kind of traumas. The first problem should be maybe the hemorrhagic shock because the face and the skull and the scalp are very, very well vascularized, and there is many arteries around, so bleeding is a kind of problem that you can find, and this problem can be a life-threatening emergency for some patient, especially for penetrating neck injury and some kind of big facial or scalp wounds or problem. The other one is the respiratory distress, which could be a mechanical problem because of blood clots or vomiting or teeth broken into the mouth, going into the airway, foreign bodies or anything like that. The problem can be functional problem because in some kind of highly dislocated complex fractures and especially a mandibular fracture, the tongue can move back into the airway. This is what we call the glossoptosis, as you can see on the little row on the right. And of course, the problem can be neurological because of some loss of consciousness or coma or skull or brain injury associated. So what to do when you have that kind of life-threatening emergency? Of course, we need to clean the mouth, remove all the foreign body, teeth or tooth prosthesis that you can find into the mouth. Try to aspirate the nasal, oral and pharyngeal cavities. Pull up the tongue if the tongue move back. Put some kind of nasal or buccal pack, but of course not both of them, because then the patient cannot breathe normally. And sometimes you need to go until the endotracheal intubation, or sometimes you need to go to tracheotomy. In all that kind of facial and skull trauma, you need to be aware of a spine or cervical spine associated fracture that can be associated and could be a big problem for the patient. Then we go to the clinical examination, and as you know, we have some kind of soft tissue injuries and some kind of hard tissue injuries concerning bone and teeth. So we're going to talk about all those bone fractures, mandibular fracture, Le Fort fracture, nose, zygomatic, orbital, and complex fracture of the face. First, you observe the patient and the swelling, the pain, the hematomas, all kind of wounds that you can find. Then you go to palpation of bone contours, because it's quite easy to touch and to feel the bone of the face, like the orbits, like the mandible, like the frontal bone, the forehead, and you can appreciate if there is any solution or any problem of the continuity of the bones. You can try some careful mobilization. That means that you put your hand on the forehead and take the upper jaw in your other hand and try to move the upper jaw and see if there is any movement, any dislocation of the upper jaw. This is the usual way we do. You can do the same with the lower jaw, with the mandible, and very carefully you take the right and the left in your both hands and try to see if there is any abnormal mobility. So that could be the way to make the diagnosis of facial fracture. And this is the usual way we do. Then you need to go a little bit further and try to appreciate the mandible range of motion. So try to ask the patient to open the mouth and see if there is any restricted mouth opening. And what is very important for the diagnosis and then for the treatment is to appreciate the dental occlusion. And we're going to speak about that a little bit, because this is the main objective of the treatment in those kind of fracture. You examine into the mouth and you see if there is any wound, any tooth moving, or any problem, tongue wounds, cheek wounds, or anything you can find into the mouth. Then what is very important is to appreciate the sensitivity. First, of course, appreciate the vision. If the patient can open the eyes, you can just be sure that there is a good vision. Appreciate the audition and look after any ear bleeding, and appreciate the trigeminal nerve and the sensory nerves of the face, like you can see on the little draw on the right. The sensitivity of the face is given by the trigeminal nerve, and the trigeminal nerve run into the facial skeleton. So most of the time when you have a facial fracture, you can have some hypoesthesia or anesthesia of the face. As you see, some kind of frontal fracture or upper orbital fracture can give loss of the sensitivity of the forehead. Some kind of orbital floor fracture or zygomatic fracture can give some loss of sensitivity of the middle third of the face, and some kind of mandibular fracture can give some loss of sensitivity of the lower third of the face. You need to examine the motricity and, of course, the facial nerve, and you need to examine too the eye movement to be sure that there is no problem around the eye and into the orbit that could affect eye mobility. And of course, any facial trauma need to check the spine, the cervical spine, of course, and the brain. So you need a complete neurological examination. X-rays could be helpful for those kind of trauma, even if, again, most of the time you can have a clear diagnosis just with your clinical examination. Anyway, if you can expect to have an X-rays, there is some standard position of the head into the machine that could be helpful, like a low frontal view to try to see the mandible and the lower jaw completely, and some kind of hyperextension view like you see on the right, called the Waters view. That is very helpful to see the orbits, the maxillary sinuses, and the zygomatic bones and arch. Other kind of view like this one could be helpful to examine the upper part of the mandible and the temporomandibular joint, the condyle, the neck of the condyle, and this particular area that cannot be seen with other kind of X-rays. If you have that kind of OPG machine, this is the standard X-ray to clearly examine the complete upper and lower jaw. So that kind of X-ray is quite useful, and this is one of the X-rays that we use most often in our department. Then, of course, you go to some CT scan, and the CT scan is a kind now of gold standard to see the facial fractures and problem. As you can see the face and the skull and the bones in any position, like an axial view on the left and the frontal coronal view on the right, you see that it's very helpful to understand some deep fracture into the face, into the orbit, into the skull base, or things like that. And then from those CT scan now, you can, of course, expect to do some 3D reconstruction. And for some big trauma, some complex trauma, it could be interesting to understand better the situation using that kind of reconstructions. Anyway, again, clinical examination is the main thing to go to understand and to make your diagnosis, and then, of course, to go to your treatment. Sorry. So we talk about first the soft tissues injuries. And for that, there is some general rules that you probably know. Is that the facial wounds are most of the time multiple and involve several anatomical zones. It's sometimes very easy to treat a simple wound of the lip, of the cheek, or whatever, but most of the time facial wounds are complex and affect several zones. As the face is very well vascularized, those wounds are unlikely to be infected. So this is a good thing, but we don't use antibiotics for all these wounds, except for some kind of special problem like dog bites or animal bites or things like that. But most of the time, those wounds are unlikely to be infected. Of course, there is some functional consequences, and we're going to talk about. And of course, there is some social consequences. Could say that could be some kind of aesthetic consequences, but I prefer to talk about social consequences. When you have that kind of wounds, you need to first search for what we call the noble parts of the face. And when we talk about the noble parts of the face, we talk about the facial nerve, so you need to examine clearly eye closing, smiling, movement of the face. We talk about the parotid duct, and you need to check if there is saliva into the wound. That could be could be the problem of parotid duct section. Again, you need to examine the sensitivity of the face to understand if there is any injury of the trigeminal nerve. You need to have a look to the lacrimal ducts that could be injured by some kind of eyelids wound. And for the vessels, the main one is, of course, the facial artery. That could be a problem because it's a quite big artery, and it bleeds a lot, and you need to check the continuity of this artery and make the hemostasis if needed. And then bone and teeth, because teeth are important for eating, for chewing, so need to be clear about that. The facial nerve is a complex distribution, and he has many ramifications, and most of the time it's very complicated to fix it in most of the wounds that affect the continuity of the facial nerve. We say usually that this is possible to fix a facial nerve injury in the area that you can see on the picture, just at the beginning of the trunk and the main branch. When the wound is more distal on the distribution of the nerve, most of the time it's not possible to fix it and to repair it. The parotid duct, you can see it from going from the parotid gland and then running on the masseter muscle and then perforating the buccinator muscle and going into the mouth. Sorry. So any wounds that cut the line between the tragus and the nose base or the alar nose base could affect the continuity of the parotid duct. Then the trigeminal nerve, as we said before, so there is 3 branches in this nerve, and the 5th, number 1, the ophthalmic nerve, is the nerve of the forehead and part of the nose. The 2nd branch, the maxillary nerve, is the nerve of the upper lip and the cheek, the anterior cheek and the lower eyelid. And the 3rd branch of the trigeminal nerve, called the mandibular nerve, is the nerve of the lower lip, the chin, and the posterior part of the cheek, as you see on the draw on the left. So this is the distribution of the nerve on another drawing. And as I said before, you see that the upper branch coming from the ophthalmic nerve run into the roof of the orbit, so can be injured by any fracture of the upper part of the orbit. Then, as you see there, the infraorbital nerve, which is branch of the maxillary nerve, run into the floor of the orbit and can be injured in all fracture of the orbital floor and the zygomatic bone. And then the mental nerve is a branch of the mandibular nerve, and he's got a pathway into the mandible, so can be affected by any fracture of the mandible. Here you see the lacrimal system and of course the lacrimal duct, and very often the eyelid wounds cut the lacrimal system, the lacrimal duct, and it's important to check that, because if you don't fix that problem, you have a kind of lagophthalmia and tearing problem for the patient. Let's see some kind of examples. So here the classical palpebral inferior eyelid wound, and as you can see on the right, the lacrimal, the inferior lacrimal duct is broken and need to be fixed. Nasal wound that you can find sometimes. So for that kind of problem, just need to be sure to reconstruct the inner layer, the cartilage continuity, and then the skin in the right anatomical position. You can have some more complex wounds, but I'm sure that you've seen many of them before, and you clearly know how to manage that kind of problem. Again, some complex facial and nasal wounds. Ear wounds, same problem, needs to be fixed with all layers. So the skin, the posterior part of the skin, the cartilage, and then the frontal or the anterior part of the skin, and you can have a complete anatomical reconstruction if you do that in good conditions. For that kind of wounds, sometimes we use some antibiotics because the cartilage can be infected, and this is possible to lose the ear after that kind of wounds just with an infection. A simple one, and the fixation of that. Another one. Here we have we need to be sure that there is not any problem with the facial nerve. Cheek wounds are the danger zone because of the facial nerve, because of the parotid duct. In those kind of wounds, you need to examine clearly your patient to be sure that there is no problem with the facial nerve and the parotid duct. Here you can see the patient is smiling, so we can imagine that there is no problem with the facial nerve. Here another one, but even if the wound looks simple, you need to be sure that the facial nerve works normally. So as I said before, in that kind of wounds, the limit between where I can do something for the facial nerve and where I cannot do anything for the facial nerve is some kind of line going by the external canthus of the eye. As you see here, we draw a yellow line just at the level of the lateral canthus of the eye, and if the facial nerve is in the posterior part of the line, you can try to do something for it. But if the problem is on the anterior part of the yellow line, I think it's not possible to try to do something for the facial nerve. Anyway, if you see something to do, you can try to do something. Here, that's kind of wound. This one cut the line between the tragus and the nose, so should be a problem for the parotid duct. Here, another one with a facial nerve injury, and you can see here that we fix the facial nerve into the wound. Gunshot wounds are another problem, and of course depends of the kind of the projectile that that make the wound. So in our country, it's more or less peaceful, but some people goes to suicide with gunshots, so we can have that kind of wounds in our emergency department. So sometimes some kind of steel grains, and well, there is not so much to do, but after that the patient keep some scars, some tattoo, and it's not easy to help the problem and to fix something. On the middle, you see the classic bullet trauma, and you need to see the penetrating zone, but you need to find the outer point of the bullet if the bullet has went through the face. And after that, the big lead shot with many lead projectiles that you can find all over the wound. And of course, you can maybe find some special situations like this man with the tree branch penetrating trauma. I think he was lucky, because not so far from the neck and from the carotid and the jugular vein. Another baby here with a 15-month baby with teeth brush into the face, going very far in the pharyngeal area. We are going to say that it's a lucky baby too. And then what we see a lot here in my country is dog bites, affecting most of the time children. And for those kind of wounds, there is a high risk of infection. So most of the time, we just close the wound because we want to have a good scar and good healing, and not too much functional and aesthetic problem after that. But we need to use some antibiotics to prevent all the risk of infection. We have many dog bites here in France. And sometimes we have some human bites, human biting other humans, but I think you can find that all over the world. So if we go to fracture injuries, hard tissue injuries, we're gonna separate the talk into two problems, because the treatment is a bit different from one to another. First, the fractures affecting dental relationships. I mean, fractures where you can find a problem in the occlusion, in the relationships between the upper and the lower jaw. The goal of the treatment of those kind of fracture is to recover the normal dental relationships, the normal relationships between the upper and the lower jaw. And if you find back the normal dental relationships, you have a complete fracture reduction. At the time where you find the normal occlusion, the normal dental relationships, the fracture is probably reduced. So this is very important, because most of those kind of fracture can be treated with a simple maxillomandibular fixation. So what is the normal occlusion? This is the normal occlusion. So you can have a look on that, but your patient probably has not a normal occlusion. So you need to know what is a normal occlusion, because sometimes this is the goal of the treatment. But you need to try to understand, or to know what was the situation of the patient before the fracture, and to find back the occlusion. So in those kind of fracture affecting the occlusion or the dental relationships, of course, you have the teeth fracture, but those kind of teeth fracture are most of the time, when they are isolated, the problem of the dentist or need some dental care. So you can have some partial fracture of the crown, of the root, and you can have some luxation or dislocation of the complete tooth, any kind of impaction, extrusion of the tooth, or things like that. And sometimes you need to fix the tooth when you have those kind of problem associated with other complex facial fracture. You need to fix the tooth, and most of the time, and that's what we do anywhere in the world, we just use some steel wires to fix the tooth. You have special techniques that you can find anywhere to fix the tooth on a steel wire. Mandibular fracture are a problem, very regular problem, common problem. So the topography of the fractures are shown on that slide, and you can see that 1/3 of the fracture, the mandibular fractures, affect the condyle and the condylar area. This is important to see or to understand if it is intra-articular fracture, for some functional consequences that you can imagine, or just a neck fracture. We say a high neck fracture, low neck fracture, but 1/3 of the fracture are in that area. The mechanism of those condylar or subcondylar fracture most of the time are an impact on the chin. Then the fracture can affect the dental part, and that can be the horizontal branch, the horizontal arch of the mandible, or the symphysis or the parasymphysis. And the limit between the horizontal branch and the symphysis is just the mental nerve and the mental foramen here. And sometimes the fracture can affect the angle of the mandible, or the ramus, less often, and exceptionally just be an alveolar dental fracture. Then with those kind of mandibular fracture, you have some primary bone displacement. The primary bone displacement is just because of the trauma. So it depends on the kind of trauma. If there is a lateral impact, if there is a frontal chin impact or whatever. And this is the usual situation that you can find. If you see in the picture here on the lower right of the slide, the anterior impact is going to open the mandible in the lingual cortical on the posterior part. And then you have some secondary bone displacement. These secondary bone displacement are relating to the muscles. Most of them are relating to the masticatory muscles, like the masseter, the temporal muscle, and then from the floor of the mouth muscles, like the mylohyoid muscles, which is going to move the fragments of the fracture in the direction of the fibers. So this is the traction, the secondary displacement that are relating to the masticatory muscles. As you can see, number one is the masseter muscles. Number 2 is the digastric or the mylohyoid muscles, and then the fractures open on the way of the drawing. This is the same situation for the condyle, the mandibular condyle, and the main displacement of the condyle is related to the pterygoid, lateral pterygoid muscles, because this muscle has a strong insertion, a strong fixation on the neck of the condyle, on the head of the condyle, and then on the disc of the TMJ. So all the condyle fractures are moving in that direction, in the direction of the muscle. That means going forward and going moving medially, like you see on the draw C. Here is the clinical situation that you can find just looking into the mouth, and you see that the continuity between the mandible, the right part and the left part of the mandible is not normal. So the gingiva is open. Sometimes the tooth is moving a little bit. And of course, the relationships between the upper and the lower jaw are not normal, and the patient feels that there is some problem into the occlusion and the relationships. So I think that for that kind of fracture, if you don't have an X-ray, this is not a big problem, because the diagnosis is clinical. It's a clinical diagnosis, and you don't need a lot to understand what happened into the bone. And you see the movement of the fracture, of the two parts of the fracture, and the posterior right part is moved by the mylohyoid muscle that tracks the fragment inside, and that's why you have that kind of displacement of that kind of parasymphysis fracture. This is another situation. You ask the patient to bite and to close the mouth, and you try to understand what happened. He's got some pain in the both TMJ areas, and there is what we call an open bite. So the anterior teeth cannot have any connection, any relationships. And this is the situation that you can find with bilateral condylar fracture, because those kind of fractures shorten the ramus and the condyle, and then the teeth are in that situation. They touch in the posterior part, but don't touch in the anterior part, and we call that an open bite malocclusion. And this is the situation that you have when you have a bilateral condylar fracture. So of course you can use an X-ray if you can, and see the fractures and see the displacement and try to understand the problem. Here on the upper right, upper left, you got a subcondylar fracture, not very displaced, so not a big deal. And on the lower right, you have an angle fracture, which is not a big problem too. The OPG is very good to understand sometimes, because here you see just a subcondylar fracture on the right, which could be a bit difficult to understand and to diagnose sometimes. Of course, using the CT scan is a good thing to understand some complex or associated fracture. As you can see on this one, You have subcondylar on the fracture on the right with no movement or no displacement. And you have another subcapital fracture on the left, but completely dislocated. And then you have a small fracture of the symphysis. The treatment of the mandibular fracture has some leading principle. As I said before, the main principle is to find, to restore, to recover the relationships between the upper and the lower jaw. And if you can find, first you need that your patient have some teeth, because if the patient has no teeth, this is a problem. But if the patient has the teeth and enough teeth, you need to try to find the correct relationships between the upper and the lower jaw. And you find, if you find that, the treatment goes to maxillomandibular fixation for 6 weeks. This is what you see on the slide. Sometimes you can go to surgery. Surgery should be needed to avoid the 6 weeks immobilization, because when you have that kind of immobilization, the patient has to be fed by just liquid, and cannot chew, cannot have the normal food. So if you want to avoid that kind of maxillomandibular fixation, or to reduce the duration of the maxillomandibular fixation, you can go to internal fixation using plates, screws, a wire, or whatever you can find. But anyway, the maxillomandibular fixation for 6 weeks is a correct treatment for most of the mandibular fracture. The problem is for intra-articular condyle fracture, because when you have an intra-articular condyle fracture, you are not supposed to fix it with a maxillomandibular fixation. You need to have an early active physiotherapy for those kind of fracture. So as we've seen before, when you have an association of fracture, like sometimes a symphysis fracture and an intra-articular condylar fracture, this could be important to fix the anterior symphysis fracture for treating the condylar fracture by active physiotherapy as early as you can. If you don't do any physiotherapy on those kind of fracture, you go to TMJ ankylosis. You see, this is in Cambodia, so no plate, no screws, the classic parasymphysial fracture with the displacement. You reduce the fractures just recovering the normal dental occlusion, dental relationships between the upper and the lower jaw, and you fix it with the wire of the maxillomandibular fixation. And then the patient for 6 weeks, and then the patient is treated. And the fracture is consolidated, and there is no problem. There is a surgical treatment that we can do here, because in my country we use plates and screw every day. So we need the maxillomandibular fixation to reduce the fracture in a good position, because when the occlusion is recovered, you know that the fracture is reduced. So first you do that kind of maxillomandibular fixation, then you fix the fracture with the plates and the screws. And that's what I said before. If you have a fracture of the condyle, intra-articular fracture affecting the joint, you need to explain to the patient that he needs some active physiotherapy. What it is just sliding, moving on the right, on the left, chewing a little bit, open the mouth, close the mouth, moving on the right, moving on the left, and do that every day, or at least 10 minutes, thrice a day, morning, noon, evening, and move and move and move and move. And if he doesn't move, he's going to that kind of ankylosis, and then the problem is much more complex. Upper jaw fracture that we call the Le4 fracture, as you know, Le4-1, Le4-2, Le4-3, so I go a little bit faster. The Le4-1 is that kind of fracture, just of the maxillary area. The Le4, here you can see some kinds of Le4-1 fractures, could be simple, could be more complex. The Le4-2 fracture is the fractures going to the orbit and the nasal septum, as you can see on that kind of expression. And here is another CT scan with a Le4-2 fracture. Another one here. Le4-3, this is the complete craniofacial dislocation. So goes into the roof of the orbit and the nose. Another kind of Le4-3, the face, big swelling. And the treatment is the same, because all those Le4 fracture leads to some kind of problem of dental relationships. So you find back the dental relationships, find the normal occlusion of the patient, and you fix it with just a maxillomandibular fixation. You don't need any plate, you don't need any screw to fix that kind of fracture. They can be very complex, but at the time where you can find the occlusion, you find the reduction, and you fix it with that kind of maxillomandibular fixation. Here is some kind of Le4-1 treatment, maxillomandibular fixation. Of course, sometimes, if you can, you fix it with some plates and screws. Nasal fractures. Problem in France, because in France we have some big nose, but maybe not a big problem in other countries. Complex centrofacial fracture affecting the frontal bone, the nasal bone, the orbits, the maxillars. So these ones are more complex than a simple nasal fracture. And when you have those kind of fracture of the skull base, or you suspect to have a fracture of the skull base, one of the things that you need to avoid is to put some gastric or nasogastric tube, because here you can see what happens sometimes. The nasogastric tube go into the skull, and you are not in a good situation with that kind of patient. So do not try to put a nasogastric tube in such a situation. The treatment is different for those kind of upper part of the face and the skull fractures, because you need some coronal approach and try to reduce and fix the fragment with wires or small plates and small screws. Here is another situation. Orbitozygomatic fractures are different, because when you have those kind of cheekbone fractures, you don't have any problem of dental occlusion. This is another problem. So the treatment is a bit different, and the complication and the clinical examination is a bit different. One of the problem is the aesthetic, maybe, because as you can see on these patients, the left zygomatic bone is moved backwards, and there is no relief of the cheekbone as usual. So this is not good, but there is a functional problem because when the zygomatic bone move backward like that, the lower jaw and the coronoid process and the temporal muscle, excuse me, and the temporal muscle cannot move normally. So sometimes you have some limitation of the mouth opening because of that kind of fracture. Here is the way to reduce those kind of fracture. So this is a small video that I did yesterday because we do that maybe every week. So this patient has a dislocation of the zygomatic arch. So as you see, we just make a very small incision, and then we use a hook. You see that kind of hook that you can find anywhere. And we are going to put the hook just under the zygomatic bone, and then the resident take the head, and the surgeon just pull out the bone to reduce the zygomatic arch, or to reduce the zygomatic bone. And most of the time, the reduction is enough. You don't need any fixation or any more fixation. So we do that because the patient has some kind of limitation of mouth opening, and reduction is going to give him back the right function of the mouth and the jaw. Sorry, no. And sometimes, of course, you can use some internal fixation when you have a highly dislocated zygomatic fracture. You use those kind of fixation. A special problem could be the orbital floor fracture. These fractures can be isolated or associated to other fractures, like Le4 fractures, Le4-2 fractures, and that can be associated with zygomatic fractures. And you need to explore the eye mobility. Is there any double vision, diplopia? Is there any infraorbital hypoesthesia or anesthesia? Is there any subcutaneous emphysema, because the air from the sinus or from the nose is going into the orbit or under the skin? And you need to know if there is any inferior rectus muscle entrapment. If there is any inferior rectus muscle entrapment, this is an emergency, and you need to reduce liberate the muscle in the first 12-24 hours. Here you see that most of the time this is a problem with young children. So here you see, you ask the patient to elevate the eye. On the right, it's going normally, but on the left, it doesn't move. So in that case, you have an inferior rectus muscle entrapment. That's what we call a trapdoor fractures. The floor of the floor of the orbit, the orbital floor is fractures, and there is a piece of bone that open and close. We call that trapdoor fracture, and entrap the inferior rectus muscle. Here, another children. You see, look up my finger, look up your mother, and you see on the right, the eye is moving up normally, but on the left, the eye is not moving anymore. This is another inferior rectus muscle entrapment fracture. So for that, I don't know if this one is working. No, this one is not working, but maybe I can I can show you with another way. This kind of fracture needs to be fixed, and the main treatment is just to open into the eyelid and to liberate the muscle from the fracture, from the trapdoor fracture, and be sure then that the fracture is moving correctly. I'm going to try to show you, and then I have almost finished my talk. Just need to know where I can share my screen. with another, maybe this one. Let's see this one.
Merci Sampo.
There you see, this is the normal side. So I catch the inferior muscle, the inferior rectus muscle, and I move the eye up to be sure that there is no entrapment. This is on the right. And you see, I cannot go completely up. So I understand that there is an entrapment of the muscle. Cannot move up. The muscle is fixed into the fracture. And maybe, I don't know, I'm gonna try to look at the treatment if I can. Need to share again. Need to share again with this one. So here is after the liberation of the muscle. So that was a fracture on the right. And then after liberation, okay, I catch the muscle and move up the eye, and the eye is moving normally. So this is just a simple treatment. Don't use any plate, any screws, any wire. Just need to liberate the muscle from the fracture, from the trapdoor fractures. So I think that this is the end of my talk, and let me see where I am. This is not the right one, I'm sorry. Come on, I'm sorry. Here it is. Just 1 minute, I'm just coming back. Okay, so that was the problem. Then for those kind of orbital fracture, if you don't treat them, one of the problem could be the enophthalmia, or the severe orbital dystopia that happen after some weeks of some months or some years. And you see that patient, she had an orbital floor fracture, maybe a big one. And after sometimes with no treatment, the eye is moving down into the maxillary sinus, and the eyelids are not normal and doesn't work normally. So that's why we need to fix that kind of fractures. So to fix an orbital floor fracture, sometimes you can use just a small piece of bone graft or small piece of cartilage from the ear or from the nose. This is not a big deal. You can do that with the simple method. So in conclusion, you have many different situations, and the standard care of those kind of trauma is unknown even in my country. So this leads to severe complication, as you've seen on some slides before. So the real life-threatening emergency are rare. There is not often somebody calling you for coming 1 minute for some problem. And however, most of the maxillofacial trauma must be fixed or operate on within the first 2 days for 48 hours. The problem is that if you don't treat them, you have some functional and aesthetic consequences. And this is, again, a problem in all countries, not in yours, but also in my country. So thank you very much for your attention. If you have any question, I'm ready to answer.
Thank you, Frédéric. very interesting. So now you can